of a course.
Thank you so much, Mudit. I'll share my screen. I hope my screen is visible and
Yes, it is.
audible. Okay. So we all know that visualization is the key for any posterior segment surgery, and there has been revolution uh, for in past 1 or 2 decades regarding the equipment and wide field viewing systems, but they all depend on the clear ocular media. And we must remember that if there is any problem in the ocular media, which may be in terms of visualization through cornea or in the anterior chamber or in the lens. Now most of the times we do encounter the lens pathologies, but we are habitual to tackling lens opacities easily, which we can do now. But the cornea remains the issue because availability of the corneal tissue is a problem in majority of the setups. Temporary K-Pro is one of the methods to tackle that, but then again it poses a problem because you need a graft immediately after the completion of the surgery, which may again not be available in all the centers. Certain anterior chamber pathologies like pupillary membranes, etc., may again pose a problem, and in these cases, we may resort to alternative visualization methods. Now, endoscopic visualization is one such method where we bypass the ocular media and we can directly look at the structures behind the iris. Indications, as is obvious, would include the media opacity, especially the corneal condition, uh, especially the corneal conditions which are not easy to tackle, and a retinal condition which requires quick intervention. For example, endophthalmitis or retinal detachment would be on the high priority list. The reason being, we may tackle the cornea with a graft, but by that time the retinal condition may progress and lead to poor visual outcome. So conditions like endophthalmitis, where there is involvement of the cornea, there is extensive involvement of the AC with pupillary membrane and exudates, one may resort to endoscopy method to tackle the posterior segment. Conditions like already where the keratoprosthesis has been done, the visualization may not be great through that, and we may again have to resort to endoscopic methods. Next would be something like when the location of the lesion is in the a place where we cannot see with the help of conventional visualization, even with the help of a wide angle visualization system. For example, the retroiridial area or the anterior PVR, where we can not easily see with the wide angle visualization system. One haptic of the SFIL has dislodged and we need to refix it. So these are some of the scenarios where the visualization is not good with the conventional visualization system, and one may have to resort to endoscopic visualization. Not again important from the uh, retinal perspective, but endocyclophotocoagulation, whenever required, may be done with the help of endoscopic system. Now coming to setup, it is simple setup. This is the system we have at RP Center. It is E2 system, endoscopic and laser system. Many versions of this system are available, the latest being E4 endoscopic system. The system basically consists of a console which has a probe, which is a single probe, which has ports for lighting, the camera, and the laser. Now, whole of this console is attached to this monitor, which displays the image from the camera. Now, it is very easy to understand nowadays with the onset of what we have digitally assisted vitreoretinal systems. What we have here is, rather than looking into the microscope, we look at the screen, and whatever is captured by the camera through the probe is projected onto the screen, and we have to look directly at the screen and not into the microscope. So if we are doing a diagnostic procedure, then just this bit of system, endoscopic system is required. We put a probe over here that goes inside the eye, and we look at the monitor to see what is happening inside the eye. But if you are planning a simultaneous intervention, then vitrectomy setup along with this system would also be required to tackle the pathology at the posterior segment. So this, as I mentioned, is the housing console where you have a xenon light which is attached to the probe over here. Then you have a diode laser, which is the laser aperture, which can provide laser light of sufficient intensity and duration. And we have a camera system which processes the image and which is perceived from the endoprobe and goes into the monitor at the top. Now we have various endoprobes of different gauges available. It can be 19 gauge, 20 gauge, or 23 gauge. The field which is provided is maximum in the wider bore in the 19 gauge, while it is the minimum in 23 gauge, and also the number of pixels is higher with the wider bore gauges. Now 20 gauge is the most commonly used as it gives adequate visualization, as well as we don't have to enlarge the port. Usually I use the MIVS cannula when I'm using 23 gauge port, and I think wider is the bore, it is easier for the beginners to do the endoscopy. Now, before I go into my video, just a simple step before we go inside the eye. There is a system on the probe where you can rotate the image. So before we enter the eye, we always check that the 12 o'clock, what is the 12 o'clock in the probe. And then once we go inside the eye, we go closer to the structures until the structure is visible. So in this particular case, this patient had a bullous keratopathy, aphakic bullous keratopathy, and on ultrasound we could see that the lens has dislocated, but the projection of rays was inaccurate. So before taking up the patient, we wanted to know whether we should proceed with the surgery. So we did a diagnostic endoscopy for this patient, and once we go behind, we see that there is a mature cataract which is there. We can see some retinal vessel. Disc is yet not visible. We go closer to the lens, and once we displace the lens bit toward the side, we can look at the disc. So disc is visible, which seems pale. All the vessels look closed. So this is one of the patient which is not going to get much help with the intervention. So basically, this is how the setup looks like. Indications I have already summarized. There are not many contraindications, but this is one procedure which has a long learning curve because there is no stereopsis. So one has to be really careful and go slow in the beginning because there are high chances of touching the retina and the ocular structures. But endoscopy has a definitive role in selective cases. It may be diagnostic or therapeutic. Thank you very much.
All right. Thank you so much, Dr. Vinod. I would like to now invite Dr. Rajiv Reddy, who is our chief instructor and chairman for this course, for any of comments or anything.
Hey, Vinod, that's a nice presentation and short explanation about how to use the machine to start with. If time permits, I think we have Puneet, who has an alternative for the instrument which we have shown. So at the end, we will ask him to show that alternative which he has created.
Yeah.
And that will keep it for the end. So we will go ahead with the next presentation with Mudit.
All right. Thank you so much. So are my slides visible?
So he is going to talk about the diagnostic endoscopy and its role.
Yep. So first of all, thanks to AIOC for giving us a chance to talk on diagnostic endoscopy, and to our chief instructor, Dr. Rajiv Reddy, and all of my co-instructors in this course. So I'll be speaking on diagnostic endoscopy and how endoscopy can be a very valuable addendum in our armamentarium to diagnose and prognosticate some of the cases which we see in our clinics. Now, I'll just show you a few examples of these are some of the cases which you may see where you see an eye with a failed graft or an eye with dense membranes and corneal opacities, or eyes with keratoprosthesis. Not till now, what we had to kind of make a guess about the condition of the retina and the underlying status were conventional tools like ERGs or ultrasound B scans. And while they may give us a clue to the structural integrity of the retina, the functional outcomes can still be unpredictable in these cases, and we may not be able to determine what is actually happening to the retina. And endoscopy for the first time now allows us the opportunity to go inside the eye, transcend the problems which are created by a corneal or anterior segment opacification, and visualize the eyes in these cases. So let me just show you a few examples. So this was a patient who had a failed corneal graft, and whether we go ahead and do a repeat surgery or not would depend upon the underlying status of the retina also in this case. And when we went inside, this is what endoscopy reveals to us: a good attached retina with a healthy macula and a good optic disc. And this patient successfully underwent a repeat procedure with a good visual outcome. Compared to that, you have cases like this, where while the ultrasound shows an attached retina over here in the first picture over here, what you see is a pale disc with sclerosed vessels. And this is an eye which will not be amenable to a good functional outcome, even if you go ahead and do a very good anterior segment surgery, put a keratoprosthesis or a graft in place, because you have underlying optic atrophy. Similarly, this was a case of keratoprosthesis, where though the B scan did show us a detached retina, when we went inside, we saw a totally necrotic retina over here. Again, the third case with a corneal keratograft and a B scan showed an RD, but when we went inside, you can see these extensive membranes and extensive PVR formation. So these are eyes which are not likely to benefit even in spite of a corneal intervention. So therefore, in these eyes, endoscopy allows us to visualize what is happening inside and can help us in prognosticating and also making a decision about which cases we are the ones where we can avoid doing a repeat surgery. So Dr. Vinod has already shown the setup of the machine, and what an endoscopy does is that this is how, when you do a surgery, normally what we have is a bird's eye view when we do a conventional vitrectomy. But when you do an endoscopy, you have got an end-on view where you've got an endoscopy probe over here, which focuses upon the opposite retina, and you visualize that part in your camera. So this is how the surgeon setup is. And while Vinod has already spoken on the machine, I'll not dwell upon that. But you are also supposed to know where to make your measurements from the center of the optical cylinder. So you can make a center, measure from the center and make a entry at somewhere around 6 millimeters from the center of a keratoprosthesis. Whereas if you've got an eye with a Boston keratoprosthesis or an eye with a graft, there is not much of a difficulty in making an entry. This is one of another patient of ours where we did an endoscopy. You can go inside the eye, visualize the retina as well as the disc status carefully and completely. Another patient where we could go inside and visualize the optic nerve and the status of the retina. So this is a slide which is courtesy one of my colleagues, Dr. Vivek Dave, who also does endoscopies extensively. And endoscopy can also help in visualizing the angle structures. In fact, he has shown how you can use an endoscopy to remove occult angle foreign bodies also. You can visualize ciliary bodies carefully and very easily with the help of an endoscope. So peripheral retinal evaluation, evaluation of the ciliary body, evaluation of extensive membranes in cases of uveitis where you have got a hypotony and you need to visualize the ciliary body, again can be achieved with the help of an endoscopic visualization. Again, this was one of our cases where you can see a peripheral retinal detachment with the break. So all the peripheral structures can be easily visualized with the help of an endoscope. So going ahead, we have devised a kind of an endoscopy form which can help in documenting what are the features which we usually document whenever we do a diagnostic endoscopy. So when it comes to anterior segment, we usually document the status of the angle, ciliary body, posterior surface of the iris, status of the lens, zonules, and the pars plicator. And for posterior segment findings, we usually do end up documenting what happened to the optic disc, macula, blood vessels, and the peripheral retina. So based on all of this, we also did a study where we tried to evaluate the effectiveness of endoscopy in posterior segment evaluation. And what we found was, I'll just come to this, that in eyes with attached retina as well as in detached retina, we documented what are the findings. And we saw that in eyes with an attached retina, we were able to see pale disc and sclerosed vessels in 9 cases, advanced glaucomatous cupping in 10 cases. Similarly, eyes which had a detached retina on an ultrasound B scan, endoscopy helped us in realizing that 11 eyes had extensive PVR changes and would not have been probably amenable to more surgical interventions. Similarly, 2 eyes with RD had a pale disc and sclerosed vessels, and RD with retinal scarring and glaucomatous cupping were also documented and seen. So when we did a B scan, we found that there were 23 eyes which had an RD on B ultrasound, and we could even locate that with the help of a B scan, but we did have one false positive. Similarly, we had 3 false negatives, which means that there were actually no RDs, whereas an ultrasound was showing those thick membranes over there. So based on the endoscopic visualization and documentation of findings, we were able to avoid a surgery in some of these cases. So while 24 eyes underwent an endoscopic vitreoretinal procedure, 6 eyes underwent keratoprosthesis, we realized that there are a lot of patients in whom we could avoid doing a repeat surgery, avoid doing a corneal reconstruction, because when you do that, you are basically subjecting your patient to lifelong risk of an allograft, immunosuppression, and all those further surgeries. So endoscopy, specifically diagnostic endoscopy, can be a very valuable tool in visualizing what is happening inside the eye and can help in prognosticating and making your decisions easy. And with that, I would like to conclude my presentation. Thank you so much. I'll stop my share.
Thanks, Mudit. We still have time for 1 or 2 questions for this talk. Any questions from audience or a panelist?
I have one question.
Yeah.
When the diagnostic endoscopy is being done, what would you say about the disc evaluation with respect to the disc pallor? Do you think any false color perception is there with an endoscope, or do you think we can reasonably well pick up the presence of a healthy disc or relatively pale disc?
Yeah, so there can be, if you are too close to the disc and illumination is too high and where you are very close to the disc, you can still perceive a false pallor in some of these cases. And therefore it makes sense to withdraw your endoscopy illumination a little bit and then visualize the disc with that. Because if you are very close to the disc, the illumination in itself will mask your findings and you may probably end up thinking that the disc is unnecessarily too pale, whereas it might not be. So it makes sense to just withdraw your endoscopy light pipe a little bit back and then visualize the disc again.
Right. Thank you.
Vinod, do you have something to say?
I think working distance also matters. So once the working distance of the probe is very less, then you will have to go very close to the retina. So that is the point when the illumination errors will occur. But if you adjust your distance in such a way, so that will take care of this particular error.
Correct. So there is a variability to this. So I would not give too much of an importance to the disc pallor per se in case of an assessment of the disc using an endoscope. I would go more with the structural changes. How much of the disc cupping are you seeing? How much of the neuroretinal rim still there is what I would give more importance to. So the pallor is a little variable. You can still see sometimes if you have all multiple sclerosed vessels around the disc and you see a pallor, that's an obvious thing. But if it's borderline, I would not go with the pallor than structural changes. Puneet, you have anything else to add?
I think about Dr. Vinod's talk about the learning curve. I think anybody who is starting to use endoscope and learn about these technique, they can use this endoscope as a light source in every surgery, especially the 23 gauge one, so that they can have an idea how the structures look on the screen in front of them. They can do the microscopic surgery. They can use the light source of the endoscope as the illumination device and simultaneously view the structure in front of them. So if they start using it, they'll get adjusted to how is the vision in endoscopy. That is how I started learning endoscopy 10 years back.
Okay, so
I also have had one observation during diagnostic endoscopy. Sometimes one is not able to clearly gauge if it's a shallow retinal detachment or it's an attached retina. At that time, we may require one additional port and try and give a peripheral small laser burn to be sure that it's the attached retina. Possibly due to the lack of three-dimensional perception that we have.
Okay, so nice comments. And then next, we'll go to the next talk. That's going to be Dr. Vivek Dave. So he's going to talk on endoscopy and management of microbial keratitis and endophthalmitis. Vivek, you can go ahead.
Yeah, thanks, Raji. I hope the screen is shared. It's visible.
Yes.
Yeah, right. So I'll start with my talk on endoscopy in concurrent corneal infections and endophthalmitis. No financial disclosures here. Acknowledge Rajiv, who has taught this skill to me painstakingly over many years. So if we look at literature with respect to infectious keratitis and endophthalmitis, be it infectious keratitis progressing to endoph or a concurrent keratitis and endophthalmitis, there is a lot of literature. If we summarize the key take-home points, it tells us that keratitis-associated endophthalmitis forms a relatively small subset in practice per se around the world. But if you look at the Indian or the subcontinental scenario, it is much more in our clinic as compared to the Western world. 30 to 40% of them not reveal any organism. But what is a standout finding is that evisceration rates can vary from 27% to as high as 60%. So that tells us, though it may not be as common as the other form of endophthalmitis that we see, once you are faced with this sort of an entity, the chances of losing the eyeball is very high unless you do something quickly. This particular paper actually assessed risk factors for endoph requiring evisceration or enucleation, and then they found that a corneal ulcer related endophthalmitis is an independent risk factor for losing the eye. If you look at these particular case scenarios, these are typically these scenarios where you have endoph inside and cornea having got affected in a way that it does not allow you direct visualization. So what can you do in such cases? You may go for just an intravitreal injection, which will be simple and quick, but the disadvantage is that you will not get an opportunity to have a vitreous clearance. You're not able to assess the retina upfront, so your management can be optimal. Or the second approach should be to do a keratoplasty and a vitrectomy at the same sitting, giving you the advantage of an extensive vitreous clearance and a retina assessment option on table. But the graft haze is still an issue. The graft would get or may get rejected in the post-operative phase. And also now what you have done is you have removed the host cornea. So there is no opportunity for a natural corneal clearance. And this patient is a post-PK patient for life. And obviously it's a laborious process. The third would be a temporary K-Pro with a vitrectomy. Again, the same advantages, but again, similar disadvantages, that it will not allow an opportunity for the natural corneal clearance because the host tissue has been removed already. Vis-a-vis, when you look at endoscopy, it allows you extensive vitreous clearance, allows you to assess the retina on table. Cornea surgeon is per se not required at that moment because it is a pure posterior segment procedure that is being done. And it allows for a natural corneal clearance. When I say that, what I mean is you clear the vitreous cavity. You keep the patient on antibiotics with respect to the corneal involvement. Obviously, this will be a subset where the corneal involvement is not severe. But because you are now having an idea of what was there in the posterior segment and you dealt with it, you can treat the corneal affection on a medical basis and thus give the patient an opportunity to actually develop into a scar rather than losing the whole host cornea. Disadvantage obviously being the learning curve. Now, this was a paper which spoke about early pass vena vitrectomy for treatment of acute infectious endophthalmitis. A very good paper which compares timelines at which an endoph is intervened for. And this paper clearly concludes that in today's scenario, the quicker you clear the vitreous cavity in an infective endophthalmitis, better will be your results. So in that scenario, an endoscopic approach gives you the best chance to immediately know what the scenario inside is and have a complete clearance of the posterior segment. Now let's run through 3 case scenarios. This one was a 9-year-old female, history of trauma with a wire 6 days ago in the left eye, previous corneal intervention done elsewhere 3 days ago, and presented to us with a vision of PLPR accurate. This is what the eye looked like. Repaired tear, you can see an infiltrate around it, an immune stromal infiltrate around the cornea. The ultrasound showing echoes throughout the vitreous cavity. In the primary intervention, a tissue adhesive was put at the site of the corneal tear repair, and a vitreous biopsy was taken as an emergency basis. The vitreous biopsy grew in the lab, and it came out to be an Enterobacter species. So what do we have here? We have post-trauma etiology, which is a negative prognostic factor. Gram-negative organism, again a negative prognostic factor. A relatively young patient, or rather a young patient, 9-year-old. So if you do a graft, high chances of graft rejection, and no posterior segment view up front. So you don't really know what the retina is like. So classical case where an approach with endoscopy will help you. So what we did is we entered. Once we entered inside, we saw these dense exudates. Meticulously, all the exudates were cleared out. And as we cleared the exudates, we could see the retina was attached inside well. And on the posterior pole, though there was a cystoid macular edema, there was no hemorrhage or necrosis. Once we found this, intravitreal antibiotics was given. The patient was followed up medically. And this is what we had 3 months down the line. If you see, the area has completely scarred. The cornea has completely cleared. Had we gone by the conventional approach of doing a K-Pro or a therapeutic keratoplasty, we would have lost the host cornea and we would have had a graft in place, putting the patient to a risk of rejection throughout life. This is what the fundus ended up with a dramatic improvement of vision. She reached 6/18 and 12. A second scenario. 12-year-old male again, complains of decreased vision in right eye since 4 days, pain, watering, injury with a needle prick, and a PLPR inaccurate presentation. So this is again how the cornea looked like. Epithelial defect with infiltrate and a tear. Again, a stromal immune ring. Stromal immune rings tend to tell you that it's a fungal infection, or if it's a short history, give you a clinical indicator that it possibly could be a gram-negative organism. The vitreous cavity showing a lot of exudates, retina apparently looking attached. Again, a vitreous biopsy that was taken revealed it to be an Enterobacter species. This patient again underwent an endoscopic procedure wherein we went in, cleared out the vitreous cavity to the extent possible. We were able to reach the posterior pole. And when we reached the posterior pole, similar to the case that we just saw, we saw that the posterior segment looked viable. So here, the patient went a fluid exchange and underwent a silicone oil injection in view of the gram-negative etiology. This is what we were to begin with, and this is what we ended with. So you can see a little bit of BSK that has come up due to the silicone oil presence because the patient was lost to follow-up and the SOR had got delayed. But very satisfactory, this is what the posterior pole looked like. And this patient reached a vision of counting fingers at 3 meters. Last, an 52-year-old male, reduced vision in the left eye along with whitening progressive since the last 4 weeks. Presenting vision again, PLPR inaccurate, was taking topical antifungal and antibiotic drops elsewhere. Had two visits elsewhere where he was advised evisceration, and he just came to us for another opinion to see whether the eye could be salvaged. This is what the presentation was. A severely melting cornea right in the center, a dense infiltrate, hypopion, immune ring, and the posterior segment showing a lot of exudates. With this sort of a presentation, PLPR vision, I think for most of us, this seems to be a scenario where possibly the eye is lost. This is what we also had on our mind, but we thought that we would go in, possibly see what the posterior segment looks like, and then see if we had any outside chance of salvaging. So this patient, when he was taken up for surgery, this was something which was really a big learning lesson for us. We went in, we cleared the vitreous cavity like we would conventionally do in an endoscopic approach. And surprisingly, when we reached the posterior pole, the disc, macula, vessels, fovea, everything was pristinely healthy. In fact, it was so pristinely healthy that we had called our cornea colleague on table to replace the cornea with a graft, which was meticulously done. And down the line, this is what the patient looked like 1 week post-op. This is what he was 1 month post-op. And this is what he was 3 months post-op with 2200 vision. So look at how this retina is looking like. And just imagine what the pre-operative picture was and the fact that he had been advised evisceration elsewhere, which in the given clinical scenario and the given look, one would not be tempted to say that that possibly was a right clinic call. But this was something that we learned, that even if things look extremely bad outside, a B scan shows you a lot of echoes, the retina could be very well viable. We have collated our experience in a few papers, one where we have put in our experience in endophthalmitis, where in 33 cases, we saw that as the literature mentions, evisceration rate of 14 to 43%, in our study, we noticed that we had evisceration requirement coming down to 3%. Only one out of these 33 eyes actually progressed and we had to eviscerate. We've also shown that if you do a prompt endoscopic vitrectomy in post-trauma cases where the cornea is bad, this avoids unnecessary keratoplasties by giving the eye an opportunity to clear out the host cornea. And also in cases where you clear off the endophthalmitis, are left behind with a corneal scar and go ahead and do a secondary keratoplasty, you will have much better visual outcomes than attempting everything in the first go as per the conventional approach. So in conclusion, microbial keratitis with coexistent endophthalmitis is an uncommon but a grave clinical presentation. Aggressive management is warranted to achieve globe salvage. Conventionally, posterior segment access can be achieved by a K-Pro or a keratoplasty to allow for a pars vena vitrectomy. Endoscopy, though, circumvents the necessity of such a labor-intensive approach, allows for a natural resolution of corneal opacity in appropriate cases, and also avoids unnecessary keratoplasties in eyes with a poor posterior segment. So thank you very much for the attention. And in case there are questions from anyone, I'll be happy to take them. Thank you.
Excellent, Vivek. Those are really nicely managed cases, and this is the potential of having an endoscope, and then where it makes your life easy, and at times where you don't need to worry about your dependency on your cornea, on availability of corneas and cornea colleagues in those situations. So before going into the endophthalmitis, how often did you feel when you are doing vitrectomy using an endoscope, you felt that you are seeing more exudates than what you usually used to do when you are doing a regular vitrectomy? You feel that
Yes,
the
I think
exudate going on, coming, it's not, there is no end to it types.
this is a very important point you have raised. In the last 1.5 to 2 years, I have realized that the B scan, in the best of hands and best of interpretations, is really subjective. It may give us some idea as to what is in the posterior segment with respect to the amount of exudates. But once you actually go in, I have seen things either which ways. So you have a situation where you see lots and lots of exudates. This particular case, the third case that I showed, the B scan actually looks very bad, but having gone inside, once the anterior vitreous was cleared, the posterior segment hardly had any exudate. So I think this is again a standalone important application of endoscope where you can quickly go in and try and assess the viability of the eye so that you know to which way your resources need directed. From that point of view, I think B is relatively subjective, and endoscope takes away a lot of that subjectivity because it gives you a direct visualization.
That's a good point, but what I was trying to get at is when the case, suppose, have you ever done cases where you could reasonably see the retina through the hazy cornea and able to do vitrectomy, and you use an endoscope, you are able to see more exudates than what you could have seen at that time, and then you feel that you are doing more vitrectomy and than what you would have otherwise have done when you were doing a regular visualization?
Yes, I think there is an objective and a subjective element to it. I think the subjective element is because during the endoscopy, you see a small field, and as you are clearing, you tend to keep moving around. There is a perception that possibly you are clearing much more than what you would or otherwise be clearing. And the objective element to it is the fact that because you have gone in with the endoscope, what otherwise through the hazy cornea was seeming to you as if you have cleared that area, suddenly now you realize that there are still exudates there which need to be cleared.
Breathe, you have anything?
Actually, the other issue that happens in these patients of endophthalmitis is once you clear these organized exudates, still the vitreous cavity is filled with some hazy fluid. So it becomes difficult to visualize things through that hazy media, even if you have cleared the exudate part. And the same thing happens in patients with vitreous hemorrhage also, organized vitreous hemorrhage and the fresh vitreous hemorrhage. And that becomes difficulty, especially in patients with ocular trauma. I'm talking about vitreous hemorrhage. If you have removed the chunk of vitreous hemorrhage, but still there is a bleeding, and it becomes very difficult to work on a blood-filled eye.
You're saying something?
I think the major difference between what we do from the microscopic system and endoscopic system is because your depth of view is very, very limited in endoscope. So while your light is far away, you can still see a lot of depth. But with endoscope, your depth of view is very limited. So you cannot go far away from the area of your endoscope. So you have to be limited in that area, and you never know when you will encounter retina. So the golden rule with endoscopy is you see and cut only till the area you can see. You don't go beyond it. While with more wider view of conventional viewing, you can go all the way up to the retina in a single go.
So one comment about that is usually what happens in endoscope is if you are go closer to the sclerotomy, you are able to get a wider view, but you don't get a view of the retina mainly because the illumination of the retina is so less that you will not be able to see. But if you can get an illumination, what I used to do is I used to put a chandelier separately as an addition. An extra illumination will give you the illumination of the retina, so you will be able to get even the wider field.
Okay.
So that's one of the reason why you will not get a wider field when you are at the sclerotomy. You will not be able to see much. That's the reason.
Okay.
Again, the next thing which I would say is what you are talking about, cut where you can see, is a golden rule when I tell my fellows every time that you cut only when you are able to see the tip of your cutter. Otherwise, don't cut. And whenever you don't see your instrument inside, so come out and go in again. Don't keep meddling inside. You'll touch wherever it is and then cause more damage than benefit. So the one thing which I would usually suggest anyone who's doing an endoscopy is when you're going inside, go with an endoscope direct towards the sclerotomy where your active instrument is going inside. So follow that instrument from there wherever and go to wherever you want to go. So keep that active instrument in focus all throughout so that you know that the other active instrument is not going and touching anywhere. That's one of the common reasons for anyone to have an accidental touch or a break anywhere. And if suppose you miss it, don't try to get it into the field. Just come out and come back to your sclerotomy and then go back again. Don't have to get it out. Come back to a sclerotomy, direct it the endoscope towards sclerotomy and then go back again. Don't move it back into your field unless it's right next to it.
Yeah, that's very useful. Thank you. Thank you.
So Mudit, do you have anything to say?
No, nothing. I think that kind of sums up the discussion regarding all of this. You have already covered the points.
Anybody has any questions from audience? I'm not getting any audience questions anyway here. So we will go to the next talk that I'll be presenting on endoscopy in retinal detachments. Are you able to see my screen?
Yeah.
Okay. So this is a topic which I would say might touch upon in all other fields what you guys were talking about, an endoscopy in endophthalmitis or trauma or any other conditions, detachment is something which you can encounter in any of these situations. But usual visualization is something like what we are seeing here. But because of the hazy media or whatever reasons, you are not able to see the retina. So where does an endoscope gives you an advantage, as we were still discussed about, in hazy media? So that is something which has been taken for granted. Whenever there is a corneal opacity, you can't see, so you will say that fine, we'll use an endoscope, we want to see better. Like in endophthalmitis, or like what Vivek had shown, or the cases where there is, Mudit was showing of cases where there is too much of a corneal scarring and things like that. So, but other than this, I will touch upon the other three factors which we are looking at in cases where we might still encounter retinal detachments, and you use endoscope as an adjunct rather than cases where you use only endoscope to do a vitrectomy. This is an example which are cases which I was talking about, where you have a good visualization of the posterior segment. Still, is there a role of an endoscope in these patients? So those are the situations where you can visualize the vitreous base, anterior PVR, and microcorneas. So this is what I'm going to touch upon right now. So this is what Mudit has shown, where the hazy media, where you can actually see what's happening inside and things like that. So this is one of the case where you can see the hazy cornea and you see inside using an endoscope, and you see a break in the periphery, and then other retina is completely still attached. So that's one example. So that I will not go much into detail because that's what most of us will talk about. But the one point which I wanted to emphasize upon is, see this video. Are you able to see the vitreous more clearer here than what you usually? This is a clear vitreous, which is usually not that common, not easy for us to see. But using an endoscope, this is the view of the clear vitreous when you actually can get. So this is what Mudit was talking about, but this is exactly how you get an advantage of using an endoscope and still be able to visualize the residual vitreous in the periphery and the vitreous based debulking. It is more useful in those situations. We have not stained it with any triamcinolone, nothing. It's just a clear vitreous, and you are able to see little more than what we usually would have seen by using a regular visualization system. So media clarity is still there, but still you can use an endoscope as an addition. So that's what these guys have shown in cases where you use endoscope as an addition. You'll be able to clear vitreous more than what we usually used to do. So that's an advantage of using an endoscope as an adjunct in cases with retinal detachments. And second application where the visualization is still clear. This is the case where we were doing vitrectomy and you see that the retina is still not settling, and you feel that there is a light pipe chandelier which had kept it was not showing well. So if you look at it back again, so this whole retina is pulled up to the ciliary body, and you can actually see the anterior PVR being dissected here and releasing the retina from the ciliary body, and then getting that anterior PVR relieved. So this is another area where it actually helps in identifying first and treating this anterior PVR better than what we could have done with a regular visualization, which is already there. So these are the cases where you have a good visualization, you are able to do vitrectomy, but you feel that the PVR is much, and then most of the time what we'll do is, okay, it's not settling, I've cleared off all the membranes, why is the retina not settling? We feel that there is contraction of retina, maybe that's the reason you would end up cutting the retina. So this would reduce the amount of retina which you might end up cutting. So you'll be able to identify those areas, and especially in RDs with PVRs where you feel that the periphery cannot be examined with some corneal opacities, or maybe in IOL where there is little case because of the PC opacity in the periphery. All those cases where you wanted to see the periphery better than what you were seeing before, there's an advantage of having an endoscope using doing a retinal detachment surgery. The third important use is, which I was talking about, is having a microcornea. So if you see this case, this is like 5 millimeter cornea actually. So this is you can still do with retinal detachment surgery using this because you still have a 5 millimeter area, because most of these cases have cataract. You usually end up doing lensectomy and they'll have colobomas and you will not have much iris there. So you can use the whole corneal area as a pupil for you to see the retina. But the problem with this is if you look at, you will end up putting sclerotomies closer to this. So if you look at this, so see, this is where you have put a sclerotomies, and the whole area is almost like 10 millimeters from here to here. So that becomes difficult from the center to here. It's almost like even less than, if you put a biome lens here in between, all your instruments are touching your biome lens edge. And the moment you want to move a little, then you are going to move your lens, and that would result in moving of the image, and it goes off to the periphery. And then anytime you want to see the periphery, you move it, and then that goes off this view. So if you look at this, so at this area, if I was trying to, this is just showing a lensectomy for this patient where I was doing it. So the moment I try to get there, see, the image is going off the center. So I still try to get it back, and then when I move, then you can see the haziness which is coming up, and then you try to move it. So that's where you have an advantage of an endoscope. And so if you, so when you see here, so till now I was struggling hard, and when I changed over to an endoscope, so that's the view. So there is no movement, and you can actually see everything clearly, and you're able to manage things better. The moment you want to see the periphery, you can actually go back and see the periphery there. You can see the areas also clearly seen here. So that's an advantage of using an endoscope, where you will still be able to see the posterior pole and other areas. And the moment you want to go to the periphery, you are finding a difficulty. So that's an advantage of using an endoscope in these cases. But like everyone was talking about, the main thing that you need to worry about is lack of stereopsis. So whenever you are doing a retinal detachment using this, so make sure that you're not too close to the retina with a high suction. And like what I was talking about, always keep your instrument in your focus. And you see, there might be a little difficulty in going closer to the retina, and you have a little depth perception problems. But then that can be overcome by having a practice. So it should not be an issue. And orientation is, and again, the second one which you need to worry about. Whenever we are going in, if you move your hand with an endoscope in where the endoscope is in, just a rotation will change the orientation completely. So that's something which you should keep in mind, to keep that hand stable, so that you will not have rotation of the instruments, and then you will not know which side you're going. It becomes like an indirect. You're going in one direction that might go in other direction. So those are the disadvantages of doing with an endoscope. But these are some things which can be overcome, and then it will definitely add value to your surgery. So that's all from my talk for endoscopy in retinal detachment surgery. So I'll stop sharing. So any comments? We still have much time. Mudit, are you there?
I'm sorry, I'm on mute. Yeah, I'm there. Yeah, no, the same thing. The initial learning point, the initial learning curve can be like what Vinod said. be a bit of a challenge initially, but once you do get the hang of it, once you do start trying to localize the structures and move your instruments in plane along with your orientation, then I think it becomes easy. You can overcome most of these problems. I think sir has started. Yeah.
No, I have not started.
Okay.
I start now?
Yes, sir.
Okay. Is my screen visible?
Yes, sir.
Okay. Thank you, AIOS, for accepting this course for the first time in AIOS. We have been trying this for many years. Thank you for this time. Thank you, Rajiv, for giving me this opportunity to speak on endoscopic surgery in patients with ocular trauma. I'll be talking about 3 scenarios, that is open globe injury, intraocular foreign body, post-traumatic endophthalmitis, and also be touching about delayed cases and diagnostic role of endoscopy in patients with ocular trauma. In open globe injury, iris trauma, corneal opacification, hyphema can cause obstruction in the view of intraocular structure. Adequate surgical view is not possible with the conventional operating microscope systems. So we have 2 options in this scenario. We have temporary keratoprosthesis, and the second is endoscopy. There are studies which have compared temporary keratoprosthesis and endoscopy in these scenarios. The advantage with TKP is the availability of binocularity and stereopsis, and possibility of performing bimanual surgery, which may be required in these difficult cases. But there are issues with the temporary keratoprosthesis, that you require donor cornea. Longer operating time is required for fixing up TKP, etc. Because of the longer operating time and open sky situation, there are chances of having suprachoroidal hemorrhages, chances of graft failure because of the extensive surgery, silicone oil situation, and inflammation because of the extensive surgery. You may also require the help of anterior segment surgeons sometime, and a watertight fixation of TKP is not possible in some of the cases. Whereas endoscopy requires lesser time, and so there are lesser chances of developing PVR. Severe trauma to the iris, lens, chorioretinal damage, intraocular hemorrhage may lead to proliferative vitreoretinopathy. And this proliferative retinopathy becomes intractable if it is not treated on time. The endoscopy allows exploration of intraocular structures early in the course of the disease, and thereby reducing the chances of development of proliferative vitreoretinopathy and retinal detachment. It requires lesser surgical time, and it is beneficial where TKP cannot be used or graft is not available. Another advantage of endoscopy, especially in trauma cases, is that you don't require to indent in endoscopy procedure. And in these patients of trauma, because the wound is not stable, it is difficult to indent these patients in the conventional system. There are some issues with endoscopy, as we have discussed in the earlier talks also. The bimanual instrumentation is not possible, as one of your hand holds the endoscope. And in trauma cases, sometimes bimanual instrumentation becomes very, very, very much needed. Lack of stereopsis and binocularity is an issue. The view is 2-dimensional and it is not a 3-dimensional view, so the surgery becomes a little difficult. There is shifting perspective. You are operating and seeing in front of seeing the view in front of you on the screen. There is difficulty in depth perception, as we have already discussed. The view is small. The view is tunnel-like. Either it is 125 or 145 degree based on the type of endoscope that you are using. Another irritating issue is that the focusing is controlled by an assistant. When you're doing surgery and something is not focused, you get irritated and you have to depend on the assistant for a better focusing. Rotation of endoscope causes rotation of field of view. And all these things make this endoscopic surgery little difficult than the conventional surgery. So for all these things, you need to have some time. You require a learning curve is required. And the another issue is the cost and availability of the equipment. But definitely, endoscopy allows procedures that are not possible with microscopic view. Intraocular foreign bodies are frequent in ocular trauma, and they need early intervention because of the toxicity issues, siderosis, chalcosis, and also the chances of infection are more when there is foreign body inside the eye. Delayed surgery may also cause encapsulation of foreign body, which makes the subsequent removal of the foreign body difficult. And endoscopy allows early intervention in these cases, and endoscopy is a valid alternative for foreign body removal in these patients. Now, in the scenario of post-traumatic endophthalmitis, we all know that EVS study has confirmed the benefits of early vitrectomy in endophthalmitis. Anterior segment opacities due to trauma can often limit the standard vitrectomy for endophthalmitis in ocular trauma patients. Endoscope is useful in such situation to perform early vitrectomy. Endoscope is also helpful in visualizing anterior structures like ciliary body, which often is covered by inflammatory membranes, and that leads to intractable hypertony in these ocular trauma patients who have traumatic endophthalmitis. Now, another important role of endoscopy in patients with trauma is the ultrasound. We all know that ultrasound has varying sensitivity and specificity in picking up IOFB and retinal detachment. Dr. Mudit has already shown the pictures. Endoscopy ensures immediate diagnosis on table, and unnecessary procedures like keratoprosthesis can be avoided. Prognostication of final visual acuity is very important dimension for the management in ocular trauma. Endoscopy, by allowing the direct visualization of the intraocular structures, give a better prognostication to the operating surgeon as well as to the patient for the counseling purposes. Avli Prasad has done a surgery in that, and they also add endoscopy allows prognostication of cases with posterior segment pathology following trauma. Appropriate prognostication avoids surgery in poor prognosis cases, and in appropriate cases, endoscopic approach allows for a resolution of corneal edema and avoids the need for unnecessary keratoplasty. I'll show you two small videos. First is a metallic foreign body at the ciliary body. This was a 41-year-old male patient who sustained injury with the iron particle. Vitrectomy for intraocular foreign body removal was done 18 months back at some other center, but foreign body could not be removed. This patient had secondary glaucoma, total cataract, siderosis. A CT scan of orbit was performed that revealed a foreign body lying at the ciliary body, anterior ciliary body. This is a small video showing the removal. Cataract surgery was performed before the procedure in an attempt to visualize the foreign body through the conventional system, but the foreign body could not be visualized. So endoscope was used to localize the foreign body. These are the cut edge of the vitreous fibers, which are appearing white. This is the optic nerve, posterior pole, and I'm trying to locate the foreign body with endoscope. This is the foreign body lying at the anterior ciliary body. Now, with the help of intraocular magnet, I'll try to lift this foreign body from the surface of the ciliary body. But because of the adhesions, the foreign body is difficult to detach from the ciliary body surface. Now, with the help of vitreous cutter, the adhesions are removed. And after the removal of these adhesions, the foreign body is lifted with the help of intraocular magnet. But again, this foreign body is stuck at the small sclerotomy site. This sclerotomy site is enlarged. In this process, the foreign body falls again on the posterior pole, and this foreign body again lifted with the help of intraocular magnet and removed to the sclerotomy. This is another scenario which we have already discussed, is the role of endoscopy in diagnosis. This was a patient where endoscopy was performed in opaque cornea. This was a trauma patient referred to me for evaluation of posterior segment for performing keratoplasty procedure. This patient, this is an endoscopy picture. You can see the retina is attached. The disc looks okay, though evaluation of disc sometimes is not possible. But the overall retina in the posterior pole looks healthy. There are some fibrotic scars in the periphery. So this patient can be taken up for a procedure, although with a guarded prognosis. This patient was operated by Dr. Abhishek Kothari in Jaipur. This is the PK pictures, and this is the actual fundus picture after the surgery. This patient regained vision of 6/12 after the final procedure. So endoscopy is also a very helpful tool in assessing the posterior segment in these trauma patients. In conclusion, endoscopy has certain advantages over TKP and the conventional surgery. It allows earlier intervention. It requires lesser surgical time, so there are lesser complications, provides more time for the surgeon to find a useful corneal graft for implantation. Postoperative inflammation is less severe than after endoscopic surgery than after the TKP implantation. Endoscopy has certain disadvantages and difficulties and issues. The learning curve is quite steep. There is a difficulty because of the lack of stereopsis, limited field of view, and difficulty in performing bimanual surgery. High cost of the equipment is also an issue. But endoscopy allows procedures that are not possible with microscopic view. So endoscopy is a very useful tool for armamentarium in the VR-OT. Thank you. I have a very small video of about 3 minutes where I am showing us innovation which is cost effective and yet very efficient in performing endoscopy in posterior segment surgery.
Endoscopy is undoubtedly a versatile tool for diagnosis and treatment of complex vitreoretinal conditions. I think there are two main reasons for endoscopic surgery not being popular. The first is cost of the equipment, and the second is insufficient image quality because of the outdated components. I am presenting a novel, cost-effective, yet efficient modified portable camera endoscope for VR surgery. Commercially available endoscopy system has a base unit and a monitor. The base unit has an illumination source, video camera, an interface for the fiber optic endoscope, and optional laser photocoagulator. I present a feasible, cheaper, but more efficient approach for endoscopic surgery using a modified C-mount portable GoPro camera. The interface for the endoscope is attached to a GoPro 7 Black camera through a C-mount. Light source can be a separate LED light source, or a vitrectomy light source can also be used for illumination. This is the C-mount at GoPro camera, and the endoscopic interface is connected to the C-mount. HDMI cable is inserted in the micro HDMI port of GoPro camera and connected to a HDMI interface of a monitor. This is the touchscreen panel for the controls on the back of the camera. Your GoPro camera endoscope is ready for use now after connecting fiber optic endoscopic cable. You can use a separate LED source or a light source of vitrectomy machine and a 4K monitor for even better visualization. This is the endoscopic view with this new endoscope using a 23-gauge fiber optic cable. The resolution and illumination both are better than the commercially available system. If you connect this endoscope to a 4K monitor, the visualization will be even better. If you compare with the commercially available system, the modified GoPro camera has much higher resolution, up to 4K, much higher light sensitivity. It has facility of digital zoom. This is not a bulky system. It can be used as a mobile device. Video output is not the older S video, but an advanced HDMI output, and all that at less than 1/10 of the cost. This article in Retina was a source of inspiration for developing this useful device, that is endoscope for all. Thank you.
Thank you, Puneet.
Thank you.
Any comments?
Sir, I think that is brilliant. That is such a useful innovation, and that probably will take away this inhibition which people have that the endoscopy system can be such a costly investment. I think you have made it much more easier and much more accessible for everyone.
I think what over the years I have been using this endoscopy system for I think 7, 8, 9 years to 2012. The image quality with especially with the 23 gauge probes is not adequate, especially if you are using a laser fiber that incorporates laser. The view with the illumination and the camera fibers is little better, but still the view is not adequate. If you have to perform the surgery, you need to use a 19 or 20 gauge endoscope, in my experience. So there's always an issue of resolution with this system. And I saw this article in Retina, which appeared a couple of months back only, and I used this lockdown period for developing this system. The resolution of this camera GoPro is up to 4K. Whereas the E4, the resolution that we get in this endoscopy, commercially available endoscopy, is 420 by 240 pixels. Whereas in this, it is 3840 into 2160, that is 4K resolution. And the other main thing is we are transmitting the images through S video here. And in this camera, we are using HDMI port. The other thing is we all, except I think you are using Ingenuity screen for visualizing. That's why the view may be better. But if you buy a good 4K screen of that comes about for 30,000-40,000 rupees, and which gives a much better visualization on its screen also. So the only thing we have to arrange is the endoscopes and the interface that connects to the camera, and connect the C mount on the GoPro. So that is all we have to do. And the light source can be used of the vitrectomy machine, or you can buy a simple LED load light source, which I think does not cost more than a lakh of rupees. So as I know, the cost of the machine that you are using in LV Prasad is more than 40 lakhs. And the machine that is E4, which does not have a laser, because I have a separate laser for this, which I attach to it, is all more than 20 lakhs. So if we can reduce the cost of the machine, I think more and more people will be able to use this, a very useful device in vitreoretinal surgery. So that is what I want to convey. And if we can, because here, this is the forum where I think most of the people who are doing endoscopy in India are collected. If we can develop these instruments further, this will be of great help in performing endoscopic surgery in vitreoretinal community.
Yeah, it's very useful, sir. In spite of such a load of patients, I think I don't use endoscopy more than once a month. So that is something in a routine practice. Probably we do not get too many cases where actually endoscopy is required in so many cases.
That's exactly the reason why I showed how you can utilize in retinal detachment, where the media is still clear. Because our impression in endoscope, when we say it's not just for people where there is a complete opacity where you can't see anything. It has a value even in cases where there is a visualization possible. Let's say if you're removing a foreign body in a clear media. So many times you go and try to remove it. When you're getting it out, you struggle so hard, you don't know whether it is coming out or not. So if same thing, you have an endoscope visualization, I can actually see through whether it is coming out properly. Is there anything getting stuck? Are you pulling a retina? Are you pulling the vitreous there? All these things you'll be able to identify. These are all the uses where you can actually use an endoscope even when there is a media clarity. So like you're talking about, I use OT only once in a month. So my use is almost like once in at least once, whenever I do a surgery, I'll have at least one case where I'll be using an endoscope like that. It's like that. And I still want to do more, but the limiting factor is not just one-time cost, what Puneet was talking about. The other factor is the availability of probes. These probes are also expensive. There's a recurring cost to it, mainly because these probes, if you don't handle them well, they'll the fiber optic will break somewhere, and then the visualization becomes even more difficult, and then you have to buy another one, and each one will cost you around 1.5 to 2 lakhs.
2.7 lakhs.
Yeah. Depends on which one you buy. Yeah, so that's how it is. So that's another thing which I was talking to Puneet, whether we can actually work together, try to get from our engineering team where they can actually develop something which is low cost probes also, so that would solve our problem, and our utilization of this will become more.
Yeah.
So things like that. So any comments, Modit?
No, nothing. Thank you so much for such great videos and for your talks. And Dr. Puneet sir, thanks. That's a really great innovation. And I think we should all take it forward.
One question to Puneet, like how do you focus in this now? So like you were talking about, do you need to have an assistant to focus? Do you have an option of focusing on your own?
No, the focusing is done by the same system that is attached to the camera.
Even with this?
Yeah, even with this. But the advantage here is that this camera has a digital zoom. So you can zoom up the image with the from the camera control.
Again through the camera, not
through the camera. Yeah.
Somebody has to be there to do it again.
Yeah. The same as with this endoscope.
And is there any change in the field? What do you see?
The field is same because the acquisition system is same. So the field is same. The illumination is better. The best thing I found is the illumination. The illumination with the 23 gauge probe is poor. And when you use this GoPro camera, because this GoPro camera is mainly designed for underwater photography and adventure photography. So perhaps because of this, they have something which works well in dim light. So the visualization, the illumination quality is better. The light sensitivity is better with this camera system. And the other advantage is the digital zoom. Though when you zoom it digitally, the clarity goes down because the optical zoom is better than the digital zoom. But even then, it has an advantage because the image quality is better because of the 4K resolution.
Yeah, so that's always true with any cameras. With the digital zoom is addition, but optical zoom is always better than
always better. Yes.
How much would be the cost of this camera?
See, the cost of the camera is I think 30,000 rupees.
What specifications do you have?
See, the recommended camera was in the article that I read was GoPro 5, but GoPro 5 is an old model. Now I think GoPro 9 is available, but when I saw the configuration, I found GoPro 7 is the best suited for this. So GoPro 7 I utilized, which costed me around 30,000 rupees, and it is available on Amazon and everywhere. And the endoscope is the same. The connector is the same. That you have to buy from Endoptics. You need to have a 4K monitor of a reasonable company, which costs around 30 to 40,000 rupees.
That's okay. Monitor is something which you can even connect to the current.
You can use the Ingenuity, but the monitor that I have with this endoscopy is a Sony medical grade monitor, and this 4K monitor gives me better view than this Sony monitor which I bought 1 lakh rupees 10 years back.
Okay. And you talked about that C mount. Is that there any modifications you need to make, or is it
Actually, you have to attach a C mount, which will be done by somebody like your biomedical engineer can do it. You cannot do it on your own, but you don't have to dismantle anything. You just have to remove the cover of the GoPro and attach the C mount on the camera, which is not a very difficult job. We can share the details of that also.
Interesting.
I think you All India Institute and your hospital have biomedical engineers.
You have an engineering department who actually work on developing instruments.
I'll send you the article which I use. I have mentioned this in my video also.
Yeah.
You can take help of it, and it's not very difficult. It's not very difficult, and I think still we have certain things we can improvise. The video quality of this camera will be much better for presentations also, because this is a 4K camera.
So what's your impression about, can we make it 3D now?
Yeah, this can be done. There is I have heard a presentation in last Frankfurt Retina meeting. I tried to locate that presentation, but it's not available to me. But there was he has designed something, some software changes which was giving 3-dimensional viewing of endoscopy.
I think there is some talk in AIOS also this time. One IC is there on good video recording, where one of the speakers probably is talking about how to make your own 3D system. Would be a good idea to check that.
Usually for making it.
But that will be for Budit, that will be for the microscopic view. I think here the problem is I think that can also be done. Yeah.
Let me just check if I can get hold of that.
You need 2 cameras for that, isn't it?
Not necessary. If there are 3D cameras, available which take input from 2 sources, and if you have 2 sources from inside the eye which goes in, but only problem, I was trying to develop it some time back, but then I got stuck with some problems there, because you need to have 2 sources at a fixed distance and the different 2 angles. But here the source is variable. I keep moving it. I need to have something like a chandelier which is fixed on the eye. There are 2 chandeliers fixed on the eye, something like this, which will become 2 sources. So things like that. So okay. So about trauma, Mudit, what are your indications? Where do you use it in trauma?
The thing is that in all case of trauma, we all know that there's an early window. We have a very limited window of opportunity. If you have got an RD in a case of trauma and you leave it unattended, you will end up having extensively severe PVR changes. By that, if you wait for the cornea to clear, or if you wait for the exudates to regress, in those cases, then you will lose a window of opportunity. So any case of trauma where even if it is like your view is obscured by the tear which has been repaired, or all those cases, if you see an RD on a B scan, or if there's a slight index of doubt also, I think endoscopy is very valuable in going ahead and doing an early intervention.
I think in acute trauma, there are very few cases actually where I do endoscopy. The reason being, most of these cornea does not become too hazy. And I'm in the habit of using glycerin in these cases. So what I do is I just, because cornea does not undergo scarring so early. So if it's just edema which is hindering our visualization, what I do is I scrape off the epithelium, and then I put some glycerin as a coupling agent rather than viscoelastic for wide angle viewing system. So most of the cases, the cornea gets sufficiently clear to allow me posterior segment visualization.
So like again, was talking about in visualizing as an adjuvant, not just like complete replacement. Would that make a difference?
Yes. I got that, because silly body, foreign body is one of the things where you would probably want to use. But again, I don't think those are very common that you can't see from any other modality. So where they are strictly in the pars plana area, most of the cases with wide angle viewing systems, I'm more comfortable personally using wide angle viewing system just to indent, and I can take care of most of the cases.
Okay. So we still have 10 minutes. Any questions from anyone?
What is the choice of your endoscopic gauge for performing surgery? Do you, which 23 or 19 or 20?
Nowadays, I use mostly a 23, but if I want to have a best of the clarity, I would go for 20 gauge. That's a best trade-off. I don't go for 19 gauge, but 19 gauge is a little too big for things. But 20 gauge gives you a best of the clarity, mainly because of the number of fiber optics inside that probe.
Do you use this 23 gauge probe with laser fibers also, or just a view and camera fibers?
I use with the laser thing also.
Because the resolution with without laser fibers is better from 6,000 to 10,000, 1,000 pixel.
Yes, definitely. That will definitely be a difference. The main reason why I still use 23 gauge in spite of having little less resolution, if I can manage, is the ease of using it with the 23 gauge systems where you don't have to make another sclerotomy and whenever I want to see, sometimes you want to change your hand and go on the other side. So sometimes I use it with the left hand, sometimes I use it with the right hand. So that makes it easier for me to change whichever port I want to go through. So that's the reason why I would prefer to go through the 23 gauge, not anything else.
Do you think using your 4K monitor that you use for Ingenuity and connecting this endoscope, I think you are using it.
Yes,
makes a difference.
Yeah, because I happen to be using Ingenuity as a routine for me, so I don't have much option. So I just keep that connected it to the Ingenuity monitor, so that makes it easier for me to do it. So the advantage there for me is just have to switch. So like what I was talking about, I keep seeing through the regular visualization. I ask them to switch the source, and it goes to the endoscopy. I use an endoscope probe as a light source for me also. So the same time, so I can keep doing the regular surgery. The view is still coming, so I can just have to change it. I can see the endoscopic view. So that's an advantage with that. So, but yes, it definitely helps you if you have a larger monitor and a better monitor. It gives you better clarity. But most of the places, even in our other ORs where we don't have an Ingenuity, we usually connect it to our larger screen. So we don't use, at least for retina surgeries, we don't use that monitor which they have got it with the machine.
Yeah, that the Sony monitor is not as good as the newer systems.
We have something like what Vinod has behind him.
Yeah, I also have the same thing.
So like that, we'll use it for in every OR. So. Okay, then. So I think we're almost coming.
I just 1 second.
Okay.
Rajiv, I have a suggestion because we have time. Can we form a endoscopy forum separately on WhatsApp so that we can discuss the issues with endoscopy amongst the people who are using it and those who are interested?
Great, sir.
For sure.
Yeah.
Because these issues like development of this camera will become difficult and we will get input from many people.
Done.
We'll do that, sir.
You're the boss, whatever you say.
Okay.
You are the one whom I first contacted when I wanted to start.
Yeah. I remember. That's the bond between us. I visited you, Alvi Prasad, a couple of years back and saw your cases.
It just happens that that's my rule. Whenever I have an instrument, I use it to the maximum possible. Okay, then. Thank you, everyone. It was nice and hope that we'll meet again.
Thank you.
Thank you.
Thank you.
Thank you,
Bye-bye.
Sovan. Have
Thank
a
you,
great day.
doctors, for an informative session.
Thank you. Bye.